Good morning, everyone. It's a pleasure to be here this morning. So I thank you for the invitation, and I'm going to be talking, yes, about stakeholder engagement with the transfer approach. So before I begin, I did create the presentation without any commercial or financial relationships that could be a potential or actual conflict of interest, but I am the co-founder and coordinator for GRADE-CERQual transfer, and it's not here, but also Camelot, a tool for critical appraisal of qualitative research studies. And we did receive funding from the Norwegian Institute of Public Health and a grant from the Campbell Collaboration. So I'm going to start just by giving an introduction. For those of you who do systematic reviews regularly, this might be kind of given for you, but for the rest of you, it might be some new information. We know that decision makers need evidence about interventions. It could be any kind of question they have too. They might wonder if tablets should be used in schools to teach math, the effect of companionship during labor, the effect of housing programs on homelessness, or whether people should wear masks in public transport. Decision makers have these kind of questions all the time. Usually, and hopefully, they're looking to systematic reviews in order to answer important questions about interventions. And these systematic reviews, they can be used to provide evidence regarding the effect of the interventions. So for instance, we can all think back to COVID a few years ago. How do we reduce illness among children and caregivers in daycares? A systematic review can look at infection control measures and the effect of them. And just a spoiler alert, washing your hands is the best way. We can also use findings from systematic reviews to provide evidence about people's experiences or their perceptions of an intervention. So how might children feel about staffing patterns, like when the adults work in a residential care institution? A systematic review can look at people's experiences on that. And the findings in that are that children prefer more family-like staffing patterns. A systematic review, though, inherently and usually includes studies from a variety of contexts. And by context, I don't just mean different countries. I don't mean low, middle income versus high income countries. I'm talking about studies from countryside versus cities, where it's warm or where it's cold, where there's different geopolitical settings. Context can mean any of these things. And it's our job in a systematic review to explore the context as well and interrogate its effect on the findings. So context, how do we do that? Well, first of all, what is it? It's the multi-level environment, so not just the physical setting in which an intervention is developed, implemented, and assessed. It's the circumstances that interact, influence, and even modify the implementation of an intervention and its effects. And why should we consider it? Discussing how results are relevant for decision makers and which factors are important for contextualizing the evidence may improve uptake of evidence in decision-making processes. Trico and colleagues found that decision makers were more likely to use the findings from systematic reviews in their decision-making processes when the findings were the results of collaborations between decision makers and researchers as well. So the format and the content of a review is deemed very important, and reviews that summarize the most important findings and state implications for practice and discuss the relevance of the results to the decision maker's context will be used more in decision-making processes. So for those of you who have done a systematic review or even just read one before, this looks very typical. We identified the need for a systematic review. So either a review team thought we'd like to look at this, or they were commissioned by a department, for example, to explore the effect of something. And then a search strategy was developed. We screened titles, we extracted the data, we did a methodological assessment, we synthesized the data, and then at the end, hopefully, we did a grade assessment or a GRADE-CERQual assessment to look at certainty or confidence in the evidence. And this assessment involved some kind of assessment of indirectness for grade or relevance for GRADE-CERQual. Unfortunately, in this process, we never considered context systematically until the very end. And I will be the first to admit that it was often just a finger in the air thinking, yeah, they seem similar. It doesn't seem too indirect, without any kind of transparency or systematic approach, which is ironic given the systematicity of the rest of a systematic review. From personal experience, I can tell you that we would do these reviews. We would give the results to the stakeholders or the commissioners or the decision makers. And more than once, they were not completely satisfied with the review, either because the review question didn't actually answer the question they were interested in, so poor communication, or they were very doubtful that the findings would apply to their own setting. I live in Norway, and you can imagine that Norway is different than some other contexts, and lots of the studies we find come from the US or the UK, and there's always a thought of, well, do the findings from this context apply to our little country here? So after years of working with commissioners, we started to wonder how we could make this result better. How could we have stakeholders who were happy with the review findings and thought that we had adequately answered the question they were interested in? And when I say the question, you think that a decision maker asks a question and we answer it, but there's a lot of small elements with nuances within a research question, and we need to know that we're on the same page. So if we're talking about children, I'm talking about children 0 to 18, but the decision maker might have been talking about 0 to 25, which is the definition in some contexts. So it's very important to have this kind of clear communication from the beginning. With transfer then, we're identifying the need for the systematic review, but then we're also looking at factors that could influence transferability at the very beginning, and we're bringing those with us throughout the systematic review. We're extracting data on them, we're doing subgroup analyses using them, and we're using them to inform our indirectness or our relevance assessment in the GRADE-CERQual assessment at the end. So in order to consider context appropriately, we need to do it in collaboration with relevant stakeholders and experts. And this could be in the case, it could be a decision maker, but it might also be somebody on the ground. So somebody, a practitioner, somebody who actually implements an intervention, somebody who receives an intervention. These are the experts who know the most about the context factors that influence the effect or implementation of their intervention. We need to do it systematically and we need to do it transparently, and it's best to do it from the beginning of the systematic review process. So that brings us to the transfer approach. And before I say much about the actual approach, I just want to give some background on how it was developed. So as I mentioned before, I'd been working with commissioned systematic reviews for quite a few years before it came up that we needed to have better dialogue and more systematic dialogue, so that whether I was talking to a decision maker or one of my colleagues, we were doing it in the same systematic, transparent way. So we identified the need to have some kind of framework to assist us. So we undertook a systematic review to identify existing checklists, and we say transferability here, but for those of you who know, transferability, indirectness, generalizability, all of these words are kind of debated and how they interact together. And there are some good articles on that, but for the case of this, we're just talking about transferability. We found 25 checklists, but we didn't find any existing checklists that met our needs. So there were none that were for health and social welfare. There were no practical guidance on how to consider and assess transferability. And there wasn't anything for qualitative evidence synthesis. So we categorized the checklist criteria into different themes that emerged across, and we used that as the beginning of the transfer approach. So we developed guidance for review authors on how to collaborate with stakeholders. This was a literature review. We used informal focus groups and interviews, and then we used something called human-centered design, where we went through iterations of what a guideline would look like and got feedback before we improved it and came to the final product. At which time we did user testing to make sure it was as usable as possible. And what it looks like then is guidance for review authors on how to improve collaboration with stakeholders and systematically and transparently consider and assess transferability of review findings to the review context. So transferability factors, what are these? These are essentially just a subset of effect modifiers that are systematically present in a defined context and are hypothesized to influence the transferability of review findings to that context. And when we assess that, we're looking whether there's a substantial difference between the context of the review question and the context of the studies that contribute data to the review finding. with respect to these transferability a priori identified characteristics. So it's a systematic way to identify subset or subgroups according to context. And it looks like this. And you can see over here on the left-hand side that this is all the room for collaboration. So we collaborate with stakeholders. And as I said, stakeholders are everybody except for researchers throughout the process. And we collaborate with them to refine the review question, to make sure we're on the same page, to identify and prioritize transfer factors, to define the review context. And this is really interesting, and I'll come back to it when I go through transfer in practice. And then this review team does a systematic review, but at the end, again, we can come back to the stakeholders to discuss the transferability of the review findings and to ensure that we've understood it correctly. Some of you might be thinking that, why do we need this? Because a review team should have the necessary expertise. But the simple case is that in many review teams, you don't have always a topical context expert. You have methodological experts. So with transfer also, we really want to move away from this arbitrary LMIC versus high income country distinction, or a country level Norway versus America. We want to look at the contextual factors that actually matter. So is it the geopolitical situation? Is there religious contextual factors? Is it cold somewhere? It's these kind of factors that might have an influence. And what it looks like is a review question template, a transfer conversation guide, and then guidance on how to use the guide. So I don't expect you to be able to read this, but just here's a little excerpt. For example, if you look at the temporal context and you want to know if you'd be concerned if the data comes from contexts where the data was collected at a different point in time. So for example, if you're looking at something on mHealth, mobile health technology, you probably don't want to include studies before 2000, where mobile technology was substantially different than it is now. I mean, even, let's say, studies before 2020, before social media was as present as it is now. So those kind of things are important to consider. Sometimes, not always. The important thing with the conversation guide is that you can see that it looks like a very long list here. But the idea is not to go through every single point. It's to prioritize some of these. So these are prompts. This is a list of factors that you might want to consider when you have a conversation with stakeholders. But it is unrealistic to think that you will go through every single line by line. And some of them will be more important for others. So I think the best way to learn is to see this in practice. So we're going to use an example, actually a real example that's slightly modified. And this is that we did a systematic review about 12 years ago on housing programs on a number of days homelessness, number of days spent homeless. So one of the findings from this review was that housing programs lead to more days in stable housing compared to usual services. However, we have people in Norway who wondered if this finding actually applied to our setting. We have a different kind of welfare system than many of the studies that were included. And, how does this work together? So the idea is, let's consider context before we conduct the systematic review. So using a time machine, we're going to go back to the beginning where the decision makers are saying, we are wondering whether housing programs from homeless people in Norway have an effect, and the researchers can help them. So the first thing we want to do is define the review question. And this is in collaboration with the stakeholders. And this looks very kind of banal and straightforward, but it's very helpful for organizing, both within the review team and post-hoc when people look back on the decision that was made for the PICO. So ideally, we'll get some suggested inclusion criteria from the commissioners of the review. They're interested in everybody, every housing program, any kind of comparison. Their outcome is days homeless, days in stable housing, only RCTs, only English, and only since 2000. That's the initial criteria. But the review authors, we had some questions. We wondered if it was adults with families or single people, people with substance abuse disorders, specific models under the intervention. Are we interested in just financial support or programs with case management? There's such a huge breadth here. When it came to outcomes, could we also include employment or health or quality of life? Could we use non-randomized studies? I'm not sure how many RCTs we would be able to find. And what about other languages? They must have been done studies in French and Spanish and Chinese and other studies. What about the cutoff date? Why 2000? So we bring these questions back to the stakeholders, and in a 2-hour discussion, we come up with a final set of inclusion criteria that we agree on. We define our population. It's adults over 18 with or without families, with or without mental illness or substance abuse disorders. The different kind of programs that we're including in the intervention, the primary and the secondary outcomes. We agree RCTs are best, and then we change the context to say that we're going to have all languages and all years. So we have a very, very clear PICO now. During this meeting, we also want to sit down and talk about transferability factors. And the starting point is this long conversation guide. But before the meeting with the stakeholders, the review team has gone through this conversation guide, and we've picked out a couple of factors that we think will get the conversation going and are probably more important than some of the other factors. That's not saying we're excluding other things. It's just what we want to make sure we talk about these specific things. So for instance, the temporal context and the geopolitical context, as well as a number of others. So we go through, we talk about, and the nice thing to do this in a group work is that when you have a group of stakeholders together, they trigger ideas. So I have observed conversations between health officials from South Africa, Norway, the US, and Chile on a specific intervention. And they talked about the context of their own countries, how this was different, things that we hadn't thought of that would influence the effect and how the intervention worked. And they triggered ideas among each other. Another example is during one of these conversations, it came out that the intervention actually had a different name and a context. So one of the people who were participating came from the US and said, well, in the US, it's actually not called A, we call it X. And I thought, oh, you know what? I've seen this before. I went back and there was a newly published systematic review on the effect of X. And we actually didn't even have to do a systematic review. And it was through this conversation and the discussion that we were able to identify some of the stuff that just Googling and looking at the literature would have taken many days to find out, if at all. So after we're going through the transferability factors, and there's no stupid answer here. We go through, all of these different things could have an effect, but it's just not realistic to look at all of them in a review. So let's pick out the 3 that are the most important. What factors could influence the transferability of the review findings to the Norwegian context? And we decide it's the climate. I'm not sure if all of you know, but it's really cold here, about half the year. The length of homelessness. So the studies show that being homeless longer than 6 months leads to more permanent homelessness. And usual services. So what is the quality of the services being given out without any specific interventions? So the review team goes and does the review, and that takes a little bit of time. And one of the review findings for this review is that housing programs lead to more days in stable housing compared to usual services. But we have these transferability factors that we wonder about for all of the included studies. So we find that participants who reported less than 6 months homelessness at baseline had a different effect. There was a different effect for them than participants who reported more than 6 months homelessness at baseline. So for the transferability factor length of homelessness, there was a small difference between these two. So in our transfer table, we can see that the studies differed. We came up with this dichotomy that's more or less than 6 months. So we have minor concerns about how these will transfer to Norwegian setting. And sorry, I should go back and just say, we also, during this conversation, we define what is the context in Norway. So very briefly, in Norway, it's very cold, but also this length of homelessness, once we have a lot of people in Norway who have been unhoused for a very long time, and then it's more difficult for them to come back in housing. And then third, as most of you probably know, we have a very strong welfare state here, and the quality of the usual services is quite high. So an additional program would have to have a very good effect or be kind of extra special to have a good impact on participants. So that being said, we do have minor concerns because there is a difference between people who have been more and less homeless at baseline. We then look at the transfer factor quality of usual services. And again, we see a small effect. We can see that there's a very small effect here. And there's a variety of studies included in the systematic review. We've again dichotomized them into high or low quality usual services. And we have minor concerns that there's a slightly reduced effect in settings where they already have high quality usual services, like in Norway. For climate, all of the countries and the settings and the included studies were also winter countries. They also had winter for periods of the seasons or periods of the year. So we don't have any concerns there. That is quite similar to the Norwegian context. So overall, then we have some minor concerns about the length of homelessness, some minor concerns about the quality of usual services, but no concerns about climate. So we come up with our assessment of transferability for this review finding, and we find that for this review finding and these transferability factors, we have minor concerns for 2 of the factors and no concerns for 1. These are the explanations for why. We have some supporting studies, and then we come up with an overall assessment. And this is just moderate concerns. There are minor differences between the included studies and the review context with respect to length of homelessness and quality of usual services. And this is again for the Norwegian context. So this table can be used to support our indirectness assessment for GRADE, the grade for effectiveness. Much like the risk of bias assessment supports the risk of bias assessment in GRADE, so can the transfer table support the indirectness assessment in GRADE by giving you some systematic and transparent way to talk about why you have rated up or down, down, and how much for the indirectness grade assessment. So in this case, we would have graded down serious and minor concerns regarding differences between studies and the review context. And this helps us to be more transparent and systematic. We're then able to say that the findings may be transferable to your setting, but the effect size may be less than the estimated effect size in the review finding. Transfer can also support GRADE-CERQual assessments, and specifically the relevance assessment of GRADE-CERQual. And this again is for transparency's sake. If you use transfer in a qualitative evidence synthesis, as it has been done numerous times, then you're able to say the concerns you have regarding the relevance of the finding to the review setting. So here is a real-life example from Glenton and colleagues on healthcare workers' perceptions and experiences of communicating with people over 50 years of age about vaccination. They identified about 5 transferability factors. So they had older adults, but they looked at the age, the health, the education, the cultural backgrounds, urban or rural. The healthcare worker, the type, their own vaccine uptake, how familiar they were to the patient, the healthcare setting, so hospital or clinic, the type of vaccine and the cost, and then the age of the study. So when was the study completed? They had a review finding the manner in which healthcare workers discussed vaccines with older adults appeared to be linked to what they saw as the aim of vaccination communication. They had moderate concerns about relevance because the studies came from a small range of geographical high-income settings, and it's possible that the relationship between the healthcare workers and older adults differ in other countries or settings. So they were able to pinpoint and be very clear. This then fed into the GRADE-CERQual evidence profile. So the finding is here. The different GRADE-CERQual components are here. And you can see that here is exactly what we've written from transfer. It helps us to be systematic and transparent. Transfer is used in, I think, now almost 200 citations, so different reviews and protocols. Everything from provision of enteral feeding for critically ill children to postnatal care to vaccines. And the transfer project group is open to anybody who is interested. You just have to email me. And we have a number of published papers for those of you who are not familiar with this at all. We have the actual, the systematic review for mapping existing checklists. We have one describing the transfer approach. and user experience of the transfer approach. And if there's any questions following this, please feel free to send me an email if you'd like more support or help applying transfer in your own setting. I'm always welcome or open to supporting different systematic review processes. So just contact me. Any questions?
Thank you, Rachel. Sorry, thank you, Heather. I was saying Rachel because she tabbed a questioning chat. Yeah, thanks, Heather. That was a really interesting and comprehensive summary of it all, and it certainly got me interested in using it. I've been involved in several projects in the past that have used stakeholder engagement, so it's always nice when there's a tool or a structured way to do things. So we have one question from Rachel at the moment, but if anyone else has a question, please feel free to type them in chat and I'll read them out. So the question from Rachel is, how do you balance the different needs of stakeholders when you are having an initial conversation about the P code for the review? This was very similar to something I was going to ask as well, because I often find uh, in my day-to-day role, the root of most issues from evidence synthesis projects is the scope of them, and we all want to be very comprehensive and inclusive of systematic reviews and the evidence that's out there, but it's balancing that against what's feasible to do. Um, I suppose that's not something that's unique to the space of evidence synthesis. That's science in general, right? So how do you balance those different needs of stakeholders whilst trying to keep um, sort of a feasible and accurate scope in the form of your inclusion criteria in the PICO?
I think that's such a good question. And I'll preface my answer by saying I don't have one answer. So the majority of my work is focused on human-centered design and engaging stakeholders in different processes. And it's a bit of an art, to be honest, that comes with experience. But the first thing I think that's important whenever you're engaging non-researchers is this power imbalance that happens. And that's not just between the researcher and the stakeholders, but between the stakeholders as well. So we had a good learning opportunity, but an unfortunate example where we engaged in a project about mentoring. We engaged mentors, mentees, decision makers, program leaders, people who are kind of varied very much in the amount of power they have. And we found that the mentees and the mentors they did not want to contribute because they didn't feel like they had the capacity to provide the answers that we were looking for, which really made me think that it was an us problem. We weren't explicit enough that they are the experts. Here are people on the ground who know that in a mentor program, setting is incredibly important, whether you're out in a workplace or you're at home, or what the cultural support system around it is. So for us, that was a really important learning point. And one of the things we found out was that we tried to do this all digital. So we tried to send out a survey, and that was not successful. It is in the coming together and the kind of lowering the threshold for making it a welcoming environment and getting people kind of talking that we've seen the most success. So just starting out for a few minutes and having everybody introduce themselves. So that's one aspect of what you're talking about, kind of the balance of different needs. But that's more the different maybe egos. The needs of stakeholders. So it does seem on the one hand quite work intensive to do something like transfer. But if you think of putting the work at the front, so making something a bit front heavy instead of doing it later, you actually save time. So I would say in the end, I've saved mostly in all of the review process we've done transfer, we've saved time. It saved me having to go and do a Google Scholar check, going through the literature often of an intervention that I am relatively unfamiliar with how it works in practice, but getting people's real life explanations of how it works in practice is incredibly helpful. So it has been time saving. And then when it comes to defining the PICO, I think that you have to think about what's realistic as well. So we've had processes where decision makers have been very adamant that only certain countries are important for the review. And I have pushed back to look at the contextual factors that define these contexts. So, for instance, if a review is being done in Canada and they really only think that studies from Canada, the UK, and America and Australia are interesting, um, I would push back and say, okay, what it is about these contexts that make it most relevant to yours? Is it the geopolitical? Is it the cultural? Is it kind of the social support system that we have? Is it the welfare system? So kind of trying to interrogate people's um, stereotypes and kind of preconceived notions, because what transfer often is about is not just looking for differences between contexts, but combating these preconceived ideas that contexts are very different. So I can just give two examples. One is a review about children. I won't go into detail on it, but involved children. And with a number of questions, we kind of found out that context didn't matter, that probably children in most settings were similar in their needs for being heard and participating and the social structures around them. That whether they spoke this language or they grew up in this socioeconomic context, it wasn't as important as the idea that they needed this kind of fundamental being heard. Another review we did on employment programs, we found out in the end that, for instance, Norway and America differ substantially in how easy it is to fire people. So we kind of were thinking, well, maybe the studies from America and an employment program will be applicable to Norway because we have this kind of the structure that we have. So going through the studies, we tried to dichotomize, okay, it's easier to fire in this setting, it's less easy to fire in this setting. And what we found out was that it didn't matter. So our preconceived notions of what contextual differences were didn't actually matter. So just to, it's a very long answer, Rachel, to say that I think it's about interrogating people's preconceived notions and trying to establish kind of consensus. And having that dialogue with groups from different backgrounds can be difficult, but if you try to find kind of the common ground, but it is a practice thing. I hope I answered your question. I'm afraid I didn't, though.
That was really insightful. Thanks for that, Heather. We've got quite a few more questions that popped up in chat now.
Yeah, okay.
So this one's from Alex. They asked, how do you think transfer fits in with the broader goals for stakeholder involvement / co-production within evidence synthesis?
Yeah, so I think that stakeholder involvement, meaningful stakeholder engagement is critical to evidence synthesis for good uptake. And that's because we want to create evidence synthesis that actually answers questions and problems that people have in a way that they understand. And I think that the way transfer fits in, and I hope inspires other processes as well, is the idea that it's from the beginning and it has a very concrete goal. So the expectations of the stakeholder engagement are very clear. I think we did a systematic review on participation in COVID decision making, so stakeholder involvement there. And what we found out is that one of the kind of traps is when people don't know the expectations. So with transfer, we're able to very clearly have what are the expectations here. First, we want to come up with a clear PICO or review question, and we want to make sure we're all on the same page. But then second, we really want to interrogate context. So these are concrete goals that we can work towards. At the end, people feel like they were heard because you can tell there's a decision that's made. We did this, and you can see the results of it as well. So I think that I hope the process, it being so concrete, explicit, transparent, systematic, will inspire other similar processes.
Thanks for that response. The next one's from Mariam. They asked, just want to clarify some thoughts from your presentation. So understand that the best thing is to involve stakeholders throughout the review. process to ensure transferability. But if a review has already been done, we can apply it retrospectively and assess its transferability then. Is that correct? I'm getting it.
Yeah, that's absolutely correct. So I just give you two anecdotes. The first is that the example I showed you of homelessness, we were actually doing the homelessness review while we were developing transfer. And so the transfer conversation that I showed you happened at the end of the review. And it was unfortunate because during that conversation, we had already analyzed and finished the report. We had a conversation with just a small group, just decision makers. And they're like, these results are really interesting, but so many of the studies are coming from LA, I think, and Hawaii, where there's a lot of homelessness in the US. And there, the motivation to participate in homelessness programs is potentially really low because it's not dangerous to be outside. In Norway, it's really dangerous to be outside for 4 months of the year. And honestly, I hadn't even thought of such a banal detail as that it's really cold here and it's hard to be homeless in the winter. But how important that kind of thing was. So we were able to go back and reflect on it, unfortunately, not in the systematic way we had hoped. But then the second thing is that I know there are a couple of groups who are using transfer to develop some kind of guideline adaptation process. So when you take systematic reviews that are supposed to inform a guideline, if you extract data on context beforehand, then you're able to kind of look at that and how it apply into other settings that maybe the guidelines weren't specifically developed for to see if it would apply to. So for example, if a review was done in Norway, we've done this for the Norwegian question, but a South African team can take the findings and say, okay, well, these contextual factors were interesting and they're more or less relevant for our own setting. And on that question, I also just want to say, which is kind of outside the scope of transfer, but still something I'm a proponent of. We often do systematic reviews with a global question. So for instance, what is the effect of eating? I don't know. What is the effect of this program on this outcome? But for many of us who work for National Health Institutes or similar, we have a setting in the back of our head. We've been commissioned to do it for the South African government, the Canadian government, the Norwegian government, and we haven't been explicit about that in the systematic review. So I, with transfer, really support having two review questions. You have the global question, but then you have a secondary question related to the global set or the local setting. And that means doing two grade assessments, but it doesn't mean making findings that are more applicable to the setting that you actually were doing the commissioned review for. I'm not sure how many of you that applies to, but that's our experience.
Yeah, you're certainly right in that sense as well. And I think that really helps with the scope issue. But yeah, I'm a big proponent of more targeted contextual research questions. And especially in sort of my research field of insect-borne diseases, is very much the transmission of this diseases is very focused on depending on what you're looking at. It's very contextual.
Yeah.
And I think going back to what you're talking about transfer providing this sort of structured approach to interrogate people's preconceived biases and things, ask them, targeted questions relating to the context, the geopolitical or whatever, is certainly really helpful because I think a lot of us come with a bias towards something, but then when you're actually forced to ask, "Oh, why did I think that in the first place?" you might find it doesn't really stand on its 2 feet. Okay, we've got one final question from Andrew. So they say, when the same group of stakeholders is involved in multiple systematic reviews, arranging in-person meetings becomes difficult because of their ongoing clinical responsibilities. As a result, scheduling several meetings is often unrealistic. In our setting, we typically use Microsoft Forms to conduct stakeholder consultations, although we still convene meetings for reviews that are likely to lead to major changes. Given this context, can the transfer approach be adapted for use within Microsoft forms-based consultation process?
Oh, I completely understand both the challenge and the idea for the solution. I mean, we have to remember that we deal with people from all different areas of life too when we're doing a systematic review. So you might have stakeholders who are out in the field and kind of are not on computers or have a different kind of work nights or whatever. There's a lot of challenges about having in-person meetings. That being said, it is ideal. My experience with online stakeholder consultation is that it really lacks the engagement and richness that comes from in-person debate when you have, for example, 5 people, even on Teams. It doesn't have to be like physically in person, but if you have 2 people who are like, yeah, but in my setting, oh, but in my setting, and you get this kind of conversation, and as a qualitative researcher, you're sitting there thinking, oh, this is like really rich and interesting, and I can pull out some details here, and you just don't get that from forms. The second thing is the idea of power balance, like I mentioned earlier. So I think if you are doing it with forms, you have to be much more careful than we were when we've tried it to ensure that the person filling out the form knows that they are the expert. And even if they may not traditionally be thought of as an expert because they're a user or a participant in something, that it is adequately acknowledged and encouraged that their opinion is more meaningful than ours as a researcher, for example. But I would be super interested, Andrew, if you wanted to do some kind of pilot with transfer and MS forms and evaluate compare it to in person. I think that it would be really interesting, and kind of strategies to improve the thoughtfulness in a forms-based versus a discussion-based platform. So I think that's a really cool idea and would encourage you to do it.